So my topic is on septic hip sequelae, the type 3B or the subluxating hip. And I would acknowledge Dr. Sangeet for sharing some of his cases for this talk. Now, the type 3B hip, where you get a pathological subluxation, because basically because of the capsular distension, the spasm of the muscles, which will force the child to go into adduction and flexion. And I've seen them mostly post surgery where there's been some kind of lack of immobilization of the hip, and due to spasm, the hip subluxates. So you can get them either acute because of the pathology itself, or late because of some bony or soft tissue changes. And once you get the subluxation, you must look at the osteoid nucleus, whether it is present or absent, and one may have to do further imaging to see the status of the osteoid nucleus. The treatment is largely based on the presentation. If the child comes acutely with a painful septic hip, then before you aspirate or you do an arthrotomy, one must assess the hip instability. And then you go and proceed with your procedure. Once you know that the hip is stable clinically, still you must need to immobilize this child to prevent painful spasm post-op. Or there is clear signs of instability, then you must put a spica immediately with a small window for a wound check, followed by brace or harness till the hip is stable. Just an example of a child with neonatal septic hip subluxation. This is a 20-day-old child with left side hip subluxation, which is observed 1 week after the aspiration. His clinical parameters are improving, but his leg continued to be in adduction. And this X-ray revealed that the hip was subluxed. He was then put in a spica cast, followed by a Pavlik for 2 months. And you can see that the osteoid nucleus is well within the position, and the accidental remodeling also is good. Another girl, 1-year-old child with right side hip infection. There was marked sepsis in the hip, subluxation of the joint. This was treated with arthrotomy and immediate hip spica, and then the hip continued to stay inside. So one must use some kind of splint, either a Pavlik or a brace or a hip spica or abduction bar post-op to maintain hip stability after any kind of septic hip drainage. Now, late presentation can also happen after the onset of treatment, following treatment of the acute sepsis, and this can occur because of the growth of the proximal femur, as well as the socket can be affected. So this is an example of a child presented at 2 years. She mimicked a DDH, but there was no osteoid nucleus seen, so we did ultrasound scan to see the osteoid nucleus, and then there was a femoral head present, so we went ahead and did a open reduction and a VD arrow. The only challenge here is when you open the socket, you find that the socket is full of scar tissue. How much do you debride? How much do you remove? Again, remains challenging because you can actually damage the native cartilage. And this was the child at follow-up. So the osteoid nucleus has just appeared. It still appears very small, and this child needs further follow-up in future. So late subluxation, again, this child had a left side hip infection. Arthrotomy was done. You can see that then he later presented with a painless limb. There was a remnant of neck seen. The osteoid nucleus was not visualized. And MRI scan was done, as Preman has discussed earlier, to see the cartilaginous head and neck area. And there was a coxa magna, the head was present there. And this child underwent then close reduction with dynamic arthrogram to see the congruity of the socket, and then whereas osteotomy was done to stabilize the hip. So I think this is again a useful technique to do an improper arthrogram to gauge the shape of the head and then decide the type of procedure required. Just reviewing literature, there was a case of late subluxation of a neonatal hip. This was published from Turkey, where this child had an acute sepsis, but at 2 years presented with this picture where the hip was subluxing, and they did a pemberton osteotomy. So I was quite surprised that when I read into the article, they felt it was a coxa magna as well as a soft tissue laxity due to the previous infection, which led to this subluxation, and hence they preferred to do a pelvic procedure, looking at the shallow AI index. So progressive subluxation due to altered femoral geometry and the socket development is not uncommon, like seen in this child, where as a sequelae of sepsis, you can see that the head is subluxating. There's a remnant of overgrowth of the neck here. This was the lateral view. This child underwent varus osteotomy, the wire fixation to stabilize the head, spica for 3 months, and this was the final picture. Now, the X-rays sometimes don't match the clinical finding, and the child, will have a stable gait, will have reasonable function, but the X-rays will always show more damage than what is actually seen. Just digressing from some of the difficult deformities, this child had a subluxation with deformity. The ossific nucleus was very small. So in this paper, these authors, they did the open reduction first. We didn't succeed, so they did a 3D CT scan. But by that time, the head had grown to some extent. So they did a redo surgery, this time using the SSD approach with the trochanteric distalization as well. And then as the child got a reasonable head, they then did valgus osteotomy. So the bottom line is that these children need repeated surgeries, they need good follow-up. And, if the parents don't give up, some of them can end up with a reasonable result. This was the initial X-ray where one could think of doing a trochanteric arthroplasty, but they persisted trying to put this head back in. And there is some hope that this head has got a cartilage which is viable and may form a reasonable head. We've had some experiences like these where we had a pseudo subluxation. We tried to do a bridging fusion here, but on opening, the joint was full of pus. We had to remove the head, did a trochanteric arthroplasty. This girl is now 2 years down the line. She's got an abductor lurch and also limb length discrepancies. So just coming to the conclusion, there was this paper from Dr. Anil Agarwal from Delhi, looking at the outcome of acute septic dislocation of hip reduced at orthotomy. And their conclusion in 14 patients was that 11 of them had excellent outcome after open reduction, and some cases had an osteotomy done. But most of them will need some kind of pelvic procedure later on. Thank you. So in conclusion, hip immobilization is important after treating acute septic arthritis. Use some kind of imaging, at least ultrasound or MRI if possible, to see that the head is located. Even after doing the surgery, follow these children every 6 months to 1 year to see both the femur as well as the growth of the acetabulum and intervene when required. Thank you very much.